This conference will now be recorded. This conference will now be recorded. This conference will now be recorded.
Colors. How do y'all feel about that test?
Bad.
Bad?
Yeah, I didn't do good on that one.
Bad.
Bad.
Yeah, I don't know what it is about me. I literally started second guessing myself the worst towards that.
Yeah. I see a lot of, more than half of you miss the heart rate for a school age child. What was the other one? The psychological and social development is like the same second to infancy. It's like late adulthood because all of their late adulthood. So their skin starts to get thin, their brains shrink, blood decreases. They have like reduced elasticity in their lungs. So that was the one I saw. Any questions about that?
That's something. Let me take it again.
All right, so right into it. We have time. I have a Jeopardy game today. So we'll meet. Yeah, I know I let you guys out so early the other night. I was like, hopefully nobody takes me for it. All right, so objectives, overview of differences in living situations that you may be presented with as an EMT. We're going to see different chronic medical conditions. We've touched on a few of them, like the LVAD and stuff, but we'll just go a little bit more in depth. Review mandated reporter policy. So as an EMT, you guys are mandated reporters, so it's important to recognize that. If you notice any kind of abuse, neglect, it's up to you to report it. So if they find out you noticed it and you didn't report it, you can get in big trouble. All right, so the definition of disability, a living condition that interferes with the ability to engage in activities of daily living. It is considered developmental. I'm having this book. It is considered a developmental disability if they have chronic impairment and it's up to the age of 22. So if they develop some kind of like hydrocephaly or something up into the age of 22, cerebral palsy and Down syndrome fall in that category. So, have you guys seen the comedian that talks about Down syndrome? He's hilarious. He's like, they're having a great time. I tell people I have someone in my family with Down syndrome, and they're like, oh, I'm sorry. What are you sorry for? They're having fun. Other disabilities are a result of a traumatic injury or a medical condition. So something like ALS, right? So multiple sclerosis, where it's like a degenerative disease, right? You can get that. Parkinson's, stroke, TBI, spinal cord injury. Stop laughing at the disabled kid.
No, I'm not. Well, at least not the one on screen.
Are you laughing at me?
Nope.
I take one bite and all the peanut butter went away.
Oh. I didn't even see that. You just held an empty Reese's.
That's why I was laughing quietly. I looked over because he was like staring at it. No, he was staring at it so depressed that I just happened to look over. It just made me chuckle.
I didn't even see that. All right. So, do you have everything right now? Sorry. Okay. All right, so living situations, they look a little bit different if somebody has any kind of disabilities, right? So they are able to kind of change the way that they live and still function a lot of times. They can still drive cars, they can still do all sorts of stuff. Have you seen the people that are like completely paralyzed, but they have special contacts in that will track what they're looking at on the screen and they can communicate? So there's a lot of different like technology that they might use so they can communicate with people or even live close to normal lives. Sometimes they just have like home health care providers that are there with them. Sometimes they're in like independent living areas. There are places, like there was one out in Georgia where there was a whole compound of like developmentally delayed people living in their little houses. It was like an assisted living center, but it was for people that were developmentally delayed. What was that? Where was that guy out of? The one that had no arms or legs and just got like charged with murder?
Oh, the Olympic shooter?
Yes.
Yeah, dude.
How? That's all I want to know is how. Yeah, I guess.
You just see a CO carrying him around the jail.
Yeah. Come on. How do you put handcuffs on?
Or a straight jacket.
It has to be. All right, so terminal illnesses. We all know who this guy is, Stephen Hawking. I believe he had Lou Gehrig. So just developmentally, it progressed. He could only talk with his little computer at the end there. So they can be under the care of hospice or palliative care. So if you guys go out on somebody, if you're an EMT, if you go out on somebody that is in a hospice situation, that hospice needs to be contacted before you take them to the hospital. So a lot of hospice agencies will pull them off hospice if they are taken to the ER. So it's important to get a hold. I think it has something to do with like, a lot of times it's like if they get transported for something to do with their illness that they're being on hospice for, they consider it that like they're not a good candidate for hospice anymore because hospice is supposed to take care of you until the end of life. So if something happens related to that illness, it'll kick you out of their hospice plan because they're like, oh, hospice can't take care of you anymore. But there are other cases like I did hospice care for a very long time. Like I had a guy that fell, busted his knee open. He had to get stitches on his knee. And they never took him off hospice because it wasn't related to his condition of hospice. So it's dependent on things like that. I'm sure other agencies are a little bit different, but that's just what I was familiar with. So it's always important to ask. I'm not gonna say every. Agape Hospice is the one around here. Fantastic, great. Abby's very good at that. There's another hospice agency around here that they'll send people home like without the medications that they're supposed to have. They'll be like, oh, you need to take them to the ER to get these meds. That defeats the purpose of you being a hospice agency. You're supposed to provide this to them. So, yeah, we've had some heated debates over, I don't even know who it was. Who was that? What hospice was that guy through that yanked his catheter out?
Genesis.
What?
Genesis.
Genesis? Oh, are they out of
I see
Elko?
them a lot.
I think that they have Elko, but they're actually like based out of like Reno or something.
Yeah, they called us one night. This dude, he did not like his catheter. He cut it at one point, and they called us to
Well,
replace
no,
his
he
catheter.
didn't know how to empty it, and it was too heavy, and it was pulling on him, and so he just cut it.
Yeah.
So they called us because he needed to get it replaced, but he didn't want to go to the ER for that.
Yeah, it was the whole thing. Anywho's. All right, so hospice and palliative. Hospice, normally they are put on hospice when they're given like a 6 month, like you're gonna live for 6 more months or less. That's usually the guidelines that they use. Palliative care is more like they don't have like a suspected death date, but they do need like comfort care at some point. So they'll be put on like a palliative care. So there's a difference between the two. Not every hospice patient, you can't assume that every hospice patient is going to have a DNR. Most of them should if they're to the point of hospice, but we saw a lot in Georgia where they were on hospice and didn't have a DNR. The families would be like, they're a fighter, and you're like, grandma's 102. So yeah, don't expect that going in. They do have those advanced directives, so that's that like pulse form that we were showing you at the beginning of class, that DNR, DNI. On there, it specifies like if they don't want to be intubated, but they still want IVs, it'll specify that kind of stuff. So it's important to look at that and actually have a copy of it with you. If you can put a copy of it in your report, it's pretty important.
The family can, if something happens, the family can basically just throw that thing away.
Yeah.
It only takes you as far as the family allows it to. So if they have a false alarm or a DNR and the patient dies and the family's like, no, you need to save them, you still have to attempt resuscitation on them.
They can't come back on you, like, if you do get them back.
Nope, because it was within the family's wishes, so the easiest way to do it is start resuscitation and then just call a doctor. Because the family can pull all that stuff. It's kind of dumb, most of the time we'll try to talk them out of it, like we'll have conversations like, listen, like, there's a reason why this is here. Like,
You don't know how people are gonna react in grief, like that's the thing, I've had people threaten to punch my partners in the face, probably the nicest dude ever, but his dad just died in front of him. So he was trying to punch my partner. Like grief affects people differently, so you have to be mindful of that. Also, go ahead.
Oh, I was about to say, we had somebody threaten to shoot up the whole station last year. So,
Stole they. Yeah, also be mindful that, if anyone in here has ever taken care of a family member, like to that extent, there is such thing as caregiver fatigue. So it's very common, people that aren't like fully trained to be a caregiver, they're taking care of their parents or their kids or whoever, they get tired and they get burnt out in doing it. So, that's where we also see a lot of the abuse cases is because of that caregiver fatigue and they don't know how to react to it. So, yes. Okay. Obesity, BMI of 30 or greater. This is how you calculate a BMI. Don't memorize that, unless you want to. I mean, you can, Google's free. So, obese patients have a higher chance of getting a lot of comorbidities. So diabetes, high cholesterol, heart disease, they are at a higher risk for a lot of that stuff. A lot of times obese people are kind of ignored if they have certain like pain or anything, because a lot of times doctors or caregivers are just gonna be like, lose weight, you'll fix your problem. A lot of times that's not the problem, right? So they like to tell you to lose weight on everything, which is ridiculous. All right, so make sure if you are moving an obese patient, you have enough assistance. Don't overdo it. So I don't know if y'all know Aunt Nancy Abrams or not. She used to work here. She's the big head honcho, big wig at MedX. She hurt her back on an obese patient. She was trying to lift them. They didn't have enough people. She hurt her back. She got back to the station, never filled out a form. She ended up having to have back surgery. She slipped a disc. So make sure that you have enough people there. I have been in a scenario where the patient was too large for me to move them at all. So fire department was called. She ended up just refusing to go anyway. Like she initially called for a lift assist. We physically could not get her off her couch. Called her the blob because she didn't have any legs, but she was probably still 400 pounds. Like she looked like a blob. And like we had boards up under her trying to pry and lift and stuff, and we just couldn't get her. So I don't know how I would even deal with that differently. The only way, like honestly, her house was so packed full of stuff and furniture, we would have to move furniture outside to get her out. Like if I was to face that today. Also, bariatric surgery that can have a lot of post-op complications. Hypoglycemia. There's things called dump syndrome. I don't know if y'all have ever heard of dump syndrome, where they get their little bariatric surgery and then they like will eat certain foods and it causes them to just poop everywhere. So they call it dump syndrome. It causes a lot of abdominal pain. Also now, your GLP-1s are very common. So it is important to know that GLP-1s have some serious side effects. So if you have a patient that's taking them and they are not taking care of themselves because it's an appetite suppressant, right? So they stop eating. And yes, they are losing weight, but they get osteoporosis, they get like paralyzed gastric motility, they'll get pancreatitis, they can get a lot of problems from something like that. So it's important to know if your patient's taking anything along those lines.
if you do know somebody that's taking those GLP-1s, because they are very prominent right now, water and protein are your best friends. you're not eating enough protein, you're not drinking enough water, that's where all the side effects come in at.
And fiber.
Fiber.
Fiber. We should all be eating a lot of fiber. Nobody in here eats enough fiber every day, and they have noticed that like middle, they call it like the millennial thing that's going on right now is a lot of colon cancer. And so, you know what stops that or prevents it? Fiber intake. But nobody eats enough fiber.
So nobody wants to walk around pooping all
I don't know what to tell you. Colon cancer? Big one. Poop in a bag, poop everywhere. Okay, so homelessness. Did you have your hand raised? Oh. Yeah, I would too. So homelessness and poverty. So it's not as rampant around here as it is in other places. So it kind of depends on what city you're living in. But depending on where you work, you're going to deal with this a lot. So Vegas, I'm sure, deals with it. We dealt with it in Atlanta. I dealt with it a lot when I lived in Idaho. I was right across the bridge from Ontario, Oregon. And so they like to congregate in Oregon side, and they'd always come over to the Idaho side. So, state of not having a regular place to live. It's not called homelessness anymore. We're going to be politically correct. They are houseless.
No, they're the unhoused.
Oh, the unhoused. Yes. So, being unhoused puts them at a higher risk for a lot of different things. So,
I don't know.
and I watched a video and these people bought, like, someone was stayed like outside of a McDonald's. They bought him, they were like, I bought this homeless person this McDonald's meal. And this lady went off, was like, they're unhoused, they're not homeless. Blah, blah, blah.
Is that Fluffy?
Okay.
Did you watch the camera?
Yeah.
Going off about it.
It's like saying dead versus unalive. It's the same
It's
fucking
the same.
thing.
Yeah.
But now
So somebody got it.
Yeah.
So now can't do.
Yeah.
I mean, I'm going to do it,
So they have a higher risk of getting these kinds of things. So mental health issues either aren't addressed by them or they are downplayed by medical providers. So the amount of psych patients that were unhoused, homeless, that we took into Atlanta's hospital, and we would drive back by 30, 45 minutes later and they'd be walking down the street was insane. So malnutrition is a big one. Substance abuse is another big one. HIV/AIDS untreated is another one. Hepatitis, that's a big one. As Chaz taught me initially when I first started working in Atlanta, they should get hazard pay, because some of the stuff that I have seen homeless people live through, like I had a guy hit by a car, his bone was sticking out of his leg. He had been hit like 3 months prior, and we went out on him. His bone was still sticking out of his leg. His foot was black, and he was like, yeah, I'm just chilling. Like, totally fine. So they do deserve hazard pay. That's for sure. Homeless women may be victims of abuse, and then poverty. So just be mindful, be kind. Like, we are all just one decision away from being here. So literally, mental health break can put you there. Lots of things. So. Autism. So
She could guess.
all right, autism. Right, no, okay. So this is now called a spectrum. So who in here has heard like Asperger's, right? So they used to have like different sections of autism. There was like functioning, not functioning, Asperger's. They were all like their own little like section. So recently they have now started calling it a spectrum. So Asperger's is still, they call it on the autism spectrum. So it can be a whole spectrum. There's ODD, ADHD, OCDs in here, Tourette's, anxiety, auditory processing. So it is a spectrum. There's a lot of what they have realized is actually women are underdiagnosed, because most people Wow. I don't even have a pocket rock today. You can't even see that.
Talk about autism. Pocket rock.
So, fun fact. I'm just gonna freaking write Chaz right
Or like rock should be on there. Long as trains.
Write them on the board.
Yeah, yeah.
Right there. It's on there, it's just because.
Right, really little. Don't worry about it. So, women are usually underdiagnosed, and the reason that is because there's social norms, right? So whenever usually autism is diagnosed very early in life, usually around like you're 4 or 5, they start talking, they start walking. Usually they're a little bit delayed in their talking and walking. And then like your ADHD, like very prominent in boys, right? So you see like a young boy bouncing off the walls, and you're like, oh, it's just, ADHD, it's autism. Like they'll link that. Well, girls, a lot of times, are actually underdiagnosed because a lot of signs of autism in women is being very quiet. Well, women or little girls are expected to be quiet with it, right? So it is very underdiagnosed. So, if you ever talk to Calvin, he'll ask you all the
Did you just tell us to
psychiatric questions. So, like if you ever feel ignored in large groups, that's one of the questions you ask. You get asked how you brush your teeth, and you have to show them how you brush your teeth. So, be a range of things. The biggest one that, like when you think autism, the picture that comes to your mind is usually like the nonverbal or like severely undertreated ADHD. So being nonverbal, they have different ways of communicating. There's a lot of them will do like spelling is what they call it. So they'll have an assistant and they'll like type or they'll write. So there's actually a really cool podcast, but I'm not going to get into it right now. So involuntary escalation or meltdowns, if you go out on an autistic patient, it's really important to try and keep everything calm. So if you are worked up, if your lights and sirens are going, you're going to work them up. I've had a lot of patients. So we had a very specific 15-year-old in Atlanta that would go absolutely bonkers if you were like overstimulating him. He'd start screaming that he was going to kill people. And he wasn't a small 15-year-old either. Like
This was a freaking Andy Putz outfit.
Yeah. Yeah, we're like, you're there. And he's standing in front of a Walgreens screaming at everybody. Yeah, I also, my freaking titty twister kid.
Yeah, so here's the big thing is all autistic children, right? Is like have points about yourself, like have respect for the situation, be mindful, but also make sure the parents are paying attention because the kid that she's talking about was like grabbing on Becca very inappropriately, like multiple times, to the point that I had to step in and intervene and like move this child.
And the mom's just standing there watching him, and he's like, and I was like, oh, that hurt.
So,
Remember when I had 2 nipples?
so be mindful of that is like, be professional, but yeah. Well, so we weren't actually taking that kid. He ended up like falling on some glass and like cut his butt.
So he like slammed down on a coffee cup and cut his butt cheek open.
Yeah, like he was fine, but we ended up not taking him. But be professional, but also like don't stand there and let the autistic kid be crap.
It wasn't very cool. So yeah, it's kind of interesting to see the realm. It's very, very interesting. I'm surprised nobody made a comment about Tylenol the whole time.
I was just thinking that he needs some milk.
You need some milk. Yeah. So, children with medical conditions, again, if anybody with medical conditions, chances are that the family, the caregivers, parents, whoever, is going to have way more knowledge on any kind of device, technology that they use than you probably ever will, unless you've dealt with something like that. So I've had kids that are like have a little trach and their vent started going off. Their parents knew more about the vent than their vent than I did. So I'm just like, yeah, I'll take you. Also pay attention to the parents. So there's been a few times that I've been called for kids with medical problems, and like the symptoms that the parents were describing seemed very benign to me, but they were like, I have seen this in this, kid before, and it was really, really bad. And this is what I was told to look for. So if they tell you something like that, even though in your head you're like, this is very benign, a small fever, a higher heart rate than usual, like listen to the parents. So. There was a kid around here for a while that had tetralogy of Fallot.
The one with the thumper? He's still there.
Wait, not the cystic fibrosis, the heart condition.
Oh, the little baby.
Yeah. He was like weeks old and he had a hole in his heart. I don't know.
Pretty sick for a little bit.
Battle Mountain's not the place to live if you have a kid with something like that.
Unless you like driving a lot.
Yeah. Yeah. Well, it got to the point that the flight crews out here wouldn't even take him because he was too little, and they weren't a specialty team, so they just wouldn't take him.
Yeah. And my closest flight team to take something like that is Salt Lake. Salt Lake and Boise both have, they call them match teams, which are just like pediatric specialty teams. They come in with like nurses and freaking respiratory therapists and like all these like specialty, they come in with a bunch of specialty OB people. You want to feel stupid, but I have one of them.
They're ridiculous.
Can you get them here, like if you need them, will they come in?
Yeah, they'll come in. It's just depending on like weather and stuff. But the match teams from Boise and Salt Lake, I think the last time we brought in the match team, it was the ones from Boise.
Well, so that was, I don't know if it's still this way, but when I worked in Idaho, EMS couldn't request a match team. It had to be done through a hospital. So if you have something like that, just be mindful, just depending. I don't know if Boise's still like that or Salt Lake's like that.
We call for them. St. Luke's match team, we call for them. So.
All right, so this is an LVAD, right? So that's the one that makes your heart go for you. It's the left ventricular assist device. So that's a little backpack that we were talking about that day. We went over LVAD. This is like a feeding tube. So there's two different types. There's a G tube and there's a J tube. So it's just dependent on where it's actually placed into the stomach. But a lot of times they'll have this little feeding pump here. I've taken patients that have feeding pumps and they are like very specific at what time they need to eat. So I just had the parents bring the pump with them and they monitored all that stuff. But a lot of times the problems you'll see with this kind of stuff is like infections around the site or if it's clogged. So if they can't, push anything or pull anything out of it, usually we get called. And then these are those little at-home ventilator things. So this terrifies me to have children. I'm like, I don't want, that's so scary. I can't even imagine. All right, so sometimes dispatch has special codes. I'm gonna be honest, anytime dispatch has ever given me a special code, I'm like, what does that mean? Because like there was times, this is why we don't use 10 codes anymore, because there's a lot of confusion that comes around. Like I was actively walking into a patient's house, like putting hands on the patient, and dispatch was like, oh, you need to stand by, it's a 1018 or whatever the frick they said. And I'm like, putting the blood pressure cuff on, what's a 1018? Oh, there's possible drugs in the area, you need to wait for police to secure the scene. I'm like, I'm already here, so whatever. So a lot of times they're going away from that. But if you do have anything specific like that, it's important to know. Patients are very aware of their condition. So I've had a lot of trach patients that will tell me like it feels like I can't get the arbitrator in, or like it feels swollen, it feels like there's a mucus plug. So they'll walk you through how to fix it. But know that their training might fail anytime you get some kind of adrenaline going. I've had patients where I walk in and their vent's beeping because it's like batteries dying or something going wrong with the vent, and family's just like, I'm like, I got BDM. Yeah. So remember that there's like different parts of this trach, right? So there's like the arbitrator that goes in, and then there's the tube that sits in there. But sometimes they don't even have that. Sometimes it's just an open hole. So those mucus plugs like to clog a lot of it. And there's another slide talking about like what to do, like how to troubleshoot a trach or any tube, really. Sorry. Who in here has dealt with a trach patient before? That don't count. One thing I have seen that's really yucky is like patients don't clean their trach tubes. They'll just like, and there's that strap that goes around the back, and that thing will get disgusting. You get the smell all over the and they'll get sores. Yeah. All right, so what is normal for that patient? So again, even though something might seem very benign to you, if it's abnormal for them, they will let you know. So make sure you're listening to caregivers, family, patients. I always ask this question, not just on people that have like special devices, because you'll get somebody that's had knee pain for the last 3 weeks, and you're like, what changed today? Why is today calling 911 day? So medical direction also, a lot of times, like with the LVADs, there's other phone numbers you can call, right? So there's a phone number on the LVAD that if something starts beeping, going off, start having problems, any kind of problems, then you can just call the LVAD team. They have your little emergency number. So conduct your normal patient assessment. That is common sense. You know that.
You do anything different with like your patient assessment if they have?
Yeah, so like with an LVAD patient in particular, your assessment's going to be a little bit different because LVADs, you can't feel a pulse with them. And so you'll have to actually listen to the LVAD with your stethoscope, so that'll change. Like your trach patients, you want to make sure that you're inspecting like certain areas, like if they have like an infection around the site. Same thing with G and J tubes. So you want to do like a more focused assessment if they have something like that in that area, if that makes sense. Same thing with like colostomy bags, that's another one. They can get like infections around their colostomies and stuff. So it's important to kind of look at that. Has anyone here ever dealt with a colostomy bag? Prepare your senses. Okay, Vaseline in the nose, fantastic. They do not smell good. So once you bust that bag open, it's like you're face to face with their poop. So, all right. So a congenital disease is a disease or condition that is present at birth that may or may not be genetic. So cleft palate is considered congenital. Congenital deafness if they're born deaf, congenital blindness, congenital heart disease, so they're born with it. And then you have your acquired diseases, right? So COPD is an acquired disease. You're not born with COPD. I would say you're not born with AIDS, but you can be born with HIV. So, and then like a traumatic spinal cord injury. So whatever you're exposed to causes something that's your acquired diseases. And the little beep. So cute. All right, so chronic is something that they've been dealing with for a long time, and then acute is like it's a new onset, but you can have like an exacerbation of a chronic illness, right? So if I have COPD, right, and I'm breathing, I do my normal treatments, I'm like living, right, surviving. And then one day I just can't breathe anymore and my inhaler's not working and my steroids aren't working. That is an exacerbation. So an acute exacerbation of a chronic illness. Does that make sense? So exacerbations can happen to like CHF, COPD. You can have exacerbations of, like technically a shingles outbreak is an exacerbation because you have shingles. If you get shingles, you have it. All right, so if they have like coexisting chronic problems, it can make new acute problems worse. right? So if somebody stubs their toe, I can heal my toe, right? But if you have somebody that's a diabetic, they have a hard time healing. They're more susceptible to any kind of infections. So those are like things that you have to think about too. So diabetics don't heal quickly. If they have any kind of like immune disorder, they can also have problems healing. So. All right, so sometimes sleep apnea mask, you all have seen one of these, I'm sure. Usually we're not called for this kind of stuff. Like people are trained on this, they know what to do. I've never been called because someone's sleep apnea machine's not working. Yeah. And then these trach tubes. So there's stoma. So long-term trach may be done depending on like what's going on with them. So a lot of times if they have like a prolonged hospital stay and they're intubated, a lot of times they'll just trach them. So mucus plugs are your biggest thing with these trach tubes. So they get this little plug of mucus in there. And if you just take a little tiny bit of saline, like a flush, and put it in there, like not the whole flush, probably like 3 to 5 cc's. Yeah, don't drown them. It'll loosen that mucus up and they'll cough it up. Do not stand in front of the stoma whenever they cough. That thing will shoot. I told you guys about the hair thing. Yeah. Not my hair thing. But, dislodgement, infection. Also, if they're messing with it a lot, say that they feel like they have a mucus plug and they're sitting there coughing and messing with it a lot, that inflammation that occurs like down in there can also feel like a mucus plug. So if they're like trying to clear it, and you show up and it's like red around it, just know that inflammation can cause a lot of the same problems. I don't think that there's a high possibility of it like swelling completely shut, but just know that it feels like there's something down in there. So. Again, you might have, I can't remember the exact word for it. Sometimes they have their voice box removed entirely. So remember, if you're bagging somebody through this, sometimes you can cover their trach and bag them through their mouth. But if they've had that, I think they call it a laryngectomy, then you can't do that. You have to bag. So BBM fits perfectly right on top of this. Just like it would a tube, it can fit perfectly on there. So if you need to bag a trach patient, if you show up and they're on a ventilator and that ventilator's not working, or say they're in cardiac arrest or completely like not breathing, nothing, you'll have to bag their trach, and it fits perfectly right on there. Not with the mask, just the little connector.
Was that done on purpose or was that done?
I think it was done on purpose, but also a lot of the vent connectors are the same size because those vents can be put on ET tubes where the BBM is also put. So I think it's just by design that they all fit. Another thing I've noticed or I've seen is like where that trach actually gets dislodged. So make sure you're assessing any trach patient for that subcutaneous emphysema, that air buildup between their skin layers. Remember, it feels like Rice Krispies up under their skin. So I used to work in a nursing home where they had a trach hall, and this patient's trach got dislodged, and they were sitting there bagging it like this, and they called EMS. This was before I even had my EMT. They called EMS, and this guy's whole like chest and this was just swollen up, and they were like, "That's not in the right spot at all." So if you're having difficulty bagging, or if somebody else is having difficulty, make sure you're checking for that subcutaneous emphysema. At that point, that trach needs to come out, and you need to try holding like a baby mask over it and bagging. So that actual trach's in the wrong spot. So just pull that thing out, deflate the bulb, then pull it out. It's the same kind of bulb that's on an ET tube. Deflate that thing, put a 10 cc syringe on there, suck the air out, pull it out, and then bag them. All right, home ventilators. So they take over inhalation, exhalation. We carry ventilators here. So these are a little bit different because these are more like user-friendly. So again, that mucus plug is a common problem. You're not going to have someone that has like an ET tube in that's on a home ventilator. They're going to be on a trach. They're sent home with a trach if they need a ventilator. Power failures, mechanical failures, A lot of times, those are the first ones you're dispatched to in any kind of power outage, is anybody that's on oxygen or something like this. So this is that troubleshooting mnemonic that I was talking about. So if this is not just for trachs, this is for any tube, ET tube, trach tube, what have you. So it's called DOPE. So the first thing you check for is displacement of the tube, right? So how do we check for that?
The subcutaneous emphysema.
The subcutaneous emphysema can show up if it's an ET tube. Watch your end tidal waveform. Remember, it's supposed to be like a perfect square. If it's like not,
Shark finning.
yeah, if it's not even shark finning, like when it gets dislodged, that square, it goes from a square to like nothing. So I don't even know how to explain it. Goes from happy to sad. So displacement of the tube, listening to lung sounds, right? So obstruction or mucus plug. So with an ET tube, sometimes like it can get kinked off, and so obstruction, that would be an obstruction. So you want to make sure that it's not kinked off. If it's a trach, it's usually a mucus plug. If you observe, if you try to suction out, if you try to look for a mucus plug, your next thing you should go to is a pneumothorax or pneumonia, right? So if they're not oxygenating, if you can't get their oxygen saturations up, you want to check for a pneumothorax. Remember, any kind of positive pressure puts you at risk for a pneumothorax. So especially patients that have like really bad cancer, like lung cancer, they get those little nodules on their lungs. It's called a bleb, and it'll actually burst and cause a pneumothorax.
So when you suction out a tube or the mucus plug or any of that, it's still the full amount of suction and everything?
Yeah, so they have like specialty suction devices for, like, you'll see them in the ICUs and stuff. You shove it down, it's like a bendy little noodle looking thing, and it's called a soft tip suction catheter. So you'll put it down into the tube, you cover the hole, and then suction on your way out. So they have ones that are like completely covered in plastic. You like feed it in, hold the little button, and suction out. So there's the hospital ones are way more fancy than the ones we carry. Ours literally just look like a little noodle.
So usually if somebody has a trach or anything like that, they'll have those supplies?
Yes.
Okay.
If they have like a ventilator, I don't even know if his has one. No, it doesn't. They'll have them. Yeah.
Okay.
Usually pretty much every time I've been to anybody with a home ventilator, they'll have that suction. So, and if they have like a home healthcare nurse, they'll show you how to use it, or they'll use it. So, and you can use it too, just know like you put it in and then you suction on the way out. Really easy. And then equipment problems is your last part of your dope. So make sure you're checking the vent, make sure you're checking like the actual tubing connectors. A lot of times they'll get like loose and that thing will start alarming because it's not on there all the way. So those are things you can look for. All right, what is that?
Pacemaker?
Pacemaker, very good.
I was
So
thinking of the other
I was thinking
name.
of something else.
There's a different name. There's like a ACID or something like that. and that's-
AICD.
It's different.
different but the same.
Yeah.
Yeah, so it is different. But a lot of times these days, they're 2-in-1. They'll have a pacemaker and an internal cardiac defibrillator placed as well. They're 2-in-1. It's a 2-in-1 device. So fun fact, I just learned this whenever dealing with our stuff. If someone like has an internal cardiac defibrillator in, if you go into a crazy rhythm like VTAC, instead of just shocking you, it'll try to pace you out of it first. And then if it can't pace you out of it, it'll shock you. So a lot of these devices are a 2-in-1 these days. Like the older ones are probably just pacemakers or just defibrillators, but the newer ones, a lot of times are both. So very cool. So what this does is it's usually put in when the heart rate's too slow. So if somebody develops some kind of like crazy heart block or something, they'll get one of these put in. So there is something, sometimes they work all the time, and sometimes they're called on-demand pacemakers. So somebody that needs theirs going all the time is just firing. It just keeps it at a certain rate. Now other people, they'll have a normal heart rate, but occasionally just drop way down. And so an on-demand pacemaker will take over. So you can look at the monitor and it'll be like normal, and then like these crazy waves, and you're like, what is going on? A lot of times it's an implanted like on-demand pacemaker. So you cannot feel it The patient cannot feel it. You're not going to touch your patient and get shocked by it by any means. It's all internal. So don't worry about any of that. Now, if you're putting an AED pad on it, make sure you don't put it directly on top of the pacemaker. You want to keep it below it.
They can feel that defibrillator.
They sure can feel that defibrillator. So.
Yeah, Pastor pops them, they know. And that's one of the questions. If they have like an implanted defibrillator, anything,
It's like
Ask
a
them
6
if
out of a 10.
6 or 7 out of
something
10,
like that,
Yeah.
yeah.
Just sitting there for a second, they're like, God damn it.
Yeah.
That's
Yeah,
awesome.
I've seen it. They're just like, ah! You're like, what's going on? Yeah. So the problem with these sometimes is they can malfunction. And so it's important that they need to be put on a monitor and cardiac monitor when this thing starts going off. Because if they're not going into a lethal rhythm and it just starts shocking them because it's malfunctioning, you're going to have other problems. So there's actually like these big magnets that the hospitals carry. We used to carry them on the ambulance in Idaho, and you just set it right over there, over their little defibrillator. So if it was malfunctioning, it would shut it off. So these are also implanted. Again, you're not going to get shocked. The patient might scream at you because they're getting shocked, and that shit hurts. But if you're touching the patient at that point, you're not going to get shocked if this thing goes off. So, yeah, the patient will feel and may be upset if I shock it. I would too, jeez. So, if you go out on a patient that has one of these and it's going off, it's important to ask how many times they've gone off. It's important to try and get a 12 lead. It's important to get all of the things. They need ALS at that point. Because if they keep going into lethal rhythms or not, these things need to be identified. So there's other medications we can give on top of this that can keep them out of those rhythms. So that's an ALS.
So just like with the pacemaker, you would put the 12 lead for the upper part down below?
Yeah, yeah. So any kind of implanted device in the chest that you can see or feel or that you know is there, keep the AED pad off of it. So you don't want to fry that thing. Good question though. So the differences. So pacemaker is helping your heart maintain a normal rhythm from being too slow is why they're put in. This says from being too slow, but now they're also too fast. Like that's also a thing. And then they send low energy pulses to the heart. And then the defibrillator isn't going off all the time. That's just something that's there for any kind of lethal arrhythmias. So pacemaker can go off all the time. Defibrillator does not. Does that make sense? Okay. All right. There's also these things. I've actually never seen one of these. I've just heard about them. So these are wearable vests that are defibrillators as well. So a lot of times, from what I've heard, I've never been on one, that they talk to you as well. So it'll say like, "Do not touch patient." So it says CPR can be performed if this thing's like, "Do not do CPR." Then don't do CPR. Listen to the rest. We live in 2026.
Is that on the patient's back?
Yes. Yeah. So I think there's different kinds because I've seen other pictures where it's like all the way around. But yeah, this one's like on the back, which is interesting. But as long as that you're getting two vectors, yeah, I mean, it'll work. So very
That thing
cool.
looks like it would be annoying as shit to wear.
Yeah, I would not wear that thing.
That looks like it'd be itchy.
It's all shock advised. You're like, fuck.
Get me out of the water.
I'd rather
You're
not
like,
be
please,
cold,
God,
just
no.
get shocked. Yeah, just shocked.
Just narrating your seven.
Yeah. It's like, I'm gonna rip this Band-Aid off now.
3,
Anytime. Yeah.
Gets you on 3 instead of 1. It's on 3.
We talked about the VADs. So most common one that people are let out and about with is that LVAD. So there is such thing as like a BiVAD where it's working through both ventricles. LVADs are the ones that people are walking around with. You can see in this picture, it's implanted. There's a, go back. There's a hole in the bottom of their left ventricle. That little device is put in there, and it's literally like a pump. It just pumps their blood. Pretty cool. You can get a 12 lead on somebody with an LVAD.
It's very artifacty.
It does look very artifacty, but you can still get
Lots of extra spools.
yes. So because you can't feel pulse, right? You just start CPR on everybody with an LVAD. At what point would you start CPR? Yeah, yeah.
Oh, okay, you have to call the place first too, though, right?
So yeah, I mean, you should, if you have an LVAD patient in your area, you should be aware of it, be aware of their LVAD. If they have no signs of perfusion, I'd rather start CPR, because most of the LVADs these days that are implanted are like a 6 week, you can't do CPR for 6 weeks, and then you can start CPR. So unless they have like fresh stitches, I would still do CPR on them, because they're not getting blood flow. So brain dead or dislodged LVAD, like which one?
What are you gonna do in that 6 weeks time after you have to do CPR?
Well, the problem is that so that was the big fight at one point, but the LVAD was because of where they were placed at, how they were placed in the heart. If you did CPR on them, you have the potential to rip that LVAD out of the bottom of the ventricle, and then what happens when you put big hole in the heart? All blood goes. So that was the big thing, and so they still say that with like the 6 week thing is like it just gives us enough time to heal to where the chances of you pulling it out of the bottom of the heart goes down.
And is that why it's important to know whether there's a person in your area with that?
Yes.
Do we have any in our area?
No, there was one in Elko. I don't even know if they're still there.
But if you ever do run into this, it's always best to like pre-plan for it. So like Elko had one. I mean, they probably didn't because Elko sucks. But if normally what you would do is pre-contact their LVAD center to be like, in a case of an emergency, what steps do you want me to take? And that way their EMS service has an idea of like, if this person needs CPR, do we start CPR immediately? Do we do X, Y, Z? Like, what do we do? Because one of the most common problems with these things is dysrhythmias. And so your heart will go into a dysrhythmia. So a lot of times they don't want you to do CPR first. They want you to treat dysrhythmias first. And so they'll have you give like anti-arrhythmic medications prior to doing CPR to see if you can get any sort of perfusion back. So there's different steps that they take with these things. Around here, we don't really have to worry about it. The big thing is like travelers. And so if you have like somebody traveling through that pulls off at the exit and they have an LVAD, then that would be like my first step, which is to call their LVAD center and be like, what do you want me to do here? But
Yeah.
Do you have to like push less hard for CPR?
no, it would be the same. It would be the same CPR. That's what I said. Most of them want you to treat anti-arrhythmics first.
The only difference would be instead of using like a Lucas device or an auto pulse, they want you to do like that's the biggest thing. I'm guessing that if you have someone driving through Battle Mountain, Nevada that has an LVAD, they've had it for more than 6 weeks. It's my like general assumption. But
You hope.
yeah, why are you driving through here? Because
On my bucket list.
yeah. They're like, I really always wanted to go to the armpit of America. Oh, good. You're there. Yeah, so signs of no perfusion, what signs would that be?
Pale skin, maybe?
Pale skin,
Cyanosis.
blue, cyanosis, mottled skin, unresponsive entirely. That would be a sign of no perfusion. So most common things here are that infection on that drive line. So that drive line goes into their belly here, where this little circle is, and then it's all internal from that point. So again, if they get an infection on their drive line, that is theirs now. They live with it until the LVAD is removed. So if someone gets an infection, they are supposed to be on antibiotics from there until they get that LVAD removed. If they don't take those antibiotics, that infection goes up that drive line straight to the heart. So infections like to settle on heart valves anyway. So it's kind of like a twofer, like this just sucks. So they need to be taking their medications.
They died.
Yeah.
Ask me how I know.
That they could like accidentally pull the drive line out?
They'd have to work pretty hard.
That thing is,
That thing's in there.
they stitch it a lot.
So they're not gonna like accidentally rip it out.
No,
No.
they should like catch it on a doorknob and freaking rip it out.
Yeah.
Like it's in there.
So 2 batteries, and then they have like their little monitor thing that they carry. It has the number on there. They have certain settings on their LVAD monitors. So whenever you call, they'll ask for what's showing up on the screen. So they have like the little perfusion rates and things, numbers. They know for that patient what numbers it needs to be set at.
So it's like troubleshooting a computer.
It is.
Yeah.
Okay, that's exactly what it is. The bionic woman. Yeah.
Just don't turn it off.
Yeah.
Right?
Yeah. You
There's half on the
physically
screen.
cannot, unless you
Yeah.
take out both batteries
Got the
at
wrong
the
mind
same
in here
time.
for that. Marigold's like, reset.
Yeah.
Turn it off,
There's
turn it
no
right back
reset.
on. It'll work just
Did you do a
fine.
key reset on
I was told to turn it
We'll
off.
tell you, if you pull the battery out of one of the batteries, base free,
You're gonna hear about it.
very loud.
So there's like the 2 batteries, and then there's like another backup battery in the actual monitor thing. So chances of you taking out all of the batteries are pretty slim.
They yell very aggressively.
Okay, so NG tubes, these are placed in the nose, usually to help like feeding and stuff. We place them after we intubate somebody to help keep that gastric distension down. So, you know, when you bag somebody and you fill their belly up with air, we put those in to relieve that air. So, a lot of times it's just used for feeding your G tubes and then J tubes. Again, same kind of idea, they're just in different parts of the stomach. Like one's in the duodenum and the other one's in the duodenum somewhere. So 2 different places. So longer term nutrient delivery, another nutrient delivery system that you guys might deal with is like, what is that called? The TNP, TPN, something. There's some kind of like nutrition that they give through an IV as well. So usually that's not very common, but these are pretty common. We have a frequent flyer around here that bought an NG tube off of eBay and puts it in herself.
Oh, Jesus.
Usually they're fed. Sometimes they're not fed through it. I've had patients that have like a small bowel obstruction. They'll have an NG tube placed, and we like transport them to another hospital. So they'll hook it up to suction, and then it'll like suck out duck. Yep. All right. So infection. Always look at the sites for infection. The most common thing for your NG tubes are like they're clotted off. That's like the most common thing. So they can't get any food in or like suction out. The treatment for it, honestly, the first thing that they'll try is they try to put some kind of soda in there. Like the carbonation and the bubblies helps dislodge whatever's in there. So a lot of times the patients know that and they have tried that before you even get there. So depending on what's going on, a lot of times they'll have to just go get transported to get a new one put in. So that's usually.
So if the patient has already tried that, do you try it again to see if maybe you could do it in a better fashion?
I mean, you could try it for sure, but yeah, like we've had that before. I don't know. I'm thinking of the PICC line where we tried it and the patient tried it, and then we tried it again. Called the nurse. She told us how to try it different, and we were like, yeah, we can't get it. So we ended up taking her in anyway. And then the nurse, first try, was like, oh, I fixed it. I'm like, frick, that fixed it. Yeah. So make sure you're checking this tube clamp, please. So same kind of idea as like our IV tubing. There's a little clamp on there. You're gonna look real silly if you're like, it's not working, and you're trying to like push stuff through it and that thing's clamped. It happens to everybody, right? But make sure you're checking that. Really easy to unclamp. You just pull the little tab and it pops open. So. All right. So a lot of times they have like this little cotton or gauze around it to kind of help soak up any kind of secretions. Don't replace the dislodged tube. We're not allowed to do that. So don't yank it out and put a new one in. You will have patients that are like, just put this one in. I have an extra one. That is not a me thing. So if they are hooked up to some kind of feeding device, make sure it's higher than the actual tube. You don't want it to flow back down. So make sure that's up. Keep them in a seated position. A lot of times these things are on pumps, so you don't have to really worry too much. They're just hooked up to that little. So, and then they have these little protective caps that you can place on them. So make sure that if they're not hooked up to anything, or if you have to unhook them from their feeding source, that you're putting that cap back on there. So prevent infection, all that good stuff.
And that's not even an ALS scope of practice either.
No. No, there are, so I would say that the, exception to the rule would be maybe like a community paramedic. Because a lot of times they do a lot of home health care stuff, like their job is to keep people out of the ER, so they can bring doctors to people or certain services. And so I could see that being a thing for them to do, but in your traditional paramedic school, you're not.
Is that your kid?
Is Andy out there?
No, that's me.
That's the
That's funny.
He even looked over here too, he's like,
Yeah. Because you knew I was over here.
He's like, you know what I'm gonna do today? Go drive by this. Urinary catheters, also known as Foley catheters. So there's a few different types, right? So there's an indwelling Foley catheter that goes in. There's a little bulb that's inflated. The urine comes out. It stays. There is a straight cath. So that's another thing. Patients can straight cath themselves. It's literally a tube. They go into the bathroom. They pee and then they pull it out. And then, so depending on where that catheter is, there's something called a suprapubic catheter as well. They'll literally have a hole up here by their belly button, and that's their catheter. They're peeing out of it, but it's into a bag. So there's different types of catheters. The most common one that you're going to see is the Foley that goes right up into them, right? So if you pick up a patient with a Foley catheter, please don't trip over this thing. Don't yank on it. Make sure it's sat nicely on their lap while you're loading them up, and then kept below the patient as you're transporting them. So you don't want that thing to get yanked out. A lot of times there's a extra sticky thing on their leg. It's secured to kind of help prevent any kind of dislodgement of that. But that is an inflated bulb that is up their urethra. So if you rip that thing out while it's still inflated, what is it, Dumb and Dumber? The last Dumb and Dumber that they made, and he yanks the guy by his Foley. Ooh, that makes me ooh. He's like, come on. It's horrible. So keep the bag lower than the patient. If I'm transporting them, moving them out to the ambulance, I don't leave that thing hanging because I don't want it to get caught. So I set it on their lap until we get them into the back, and then I'll hang it down. So I don't want that thing to get yanked on at any point. Make sure that you are monitoring. Make sure you look at the color of the urine that's in there. I always know how much urine is in there as well, whenever I transport them. I also tell the nurses if they, I'll say, hey, just so you know, started out with 80 cc's or whatever. So, because they keep track of it all. Who was with me? Frank was. He just had a patient and looked like his whole catheter Foley bag system was full of blood. It was just bright red blood. So a lot of times there's clots that happen in there. They'll bleed into it. So yeah, if someone has a UTI, you'll see it in there. It's very cloudy, sedimenty. So a lot of times it looks like sand in there if they have a bad UTI. Certain medications can turn their urine blue as well. I can't remember them off the top of my head. I'll think of it. But it can turn their urine blue. Cyanokids are one of those, so it can change your urine some funky colors.
So don't freak out if you see it.
Yeah, if you see a weird blue color in a Foley, ask what meds they're on or have been given. So, again, this is not a thing that we change in the field. We're actually taught this in paramedic school, how to put one of these in. I don't do that. Those nurses get paid a lot of money to be able to put one of those things in there. We don't even carry them, so. Yeah, don't yank on it. Note the color. Note how much they have are the biggest things. A lot of times these are a great source of infection. So if you have somebody that's meeting sepsis criteria and you're where's their infection coming from? And they have one of these, 9 times out of 10, that is where it's coming from. So it's important to know the last time it was changed for something like that. I've had patients that hadn't had their Foleys changed for months. They was
How often are they supposed to change?
I think it's I don't know. I don't want to give you a false answer. Let me Google. I want to say it's like a week.
Now, if we have a patient who hasn't had one changed in a while, is that considered abuse
It can
or
be.
neglect of some sort?
Absolutely.
Okay.
Absolutely. Like the guy that I had that had his in for months and months, when they pulled up that he came from a nursing home and that man had been there for months. So this is about 2 to 12 weeks. But, professional replacement every 4 to 6 weeks. Not once a month. I just remember when they changed it, he was completely altered, obviously septic. And he was in like the CPR room at Grady, which is like one of the resuscitation big rooms. They freaking changed out the Foley catheter. They pulled that thing out and the slime that was on it, and then the smell that hit everybody, you could smell it throughout like the whole ER floor. It was absolutely disgusting. It was horrible. So yes, that is abuse and neglect, all of it. Ostomy bags. So a lot of people that have had like some kind of colon cancer, some kind of trauma, they can have an ostomy bag. So if they've had part of their bowel removed, I've seen where patients keep getting bowel blockages, so they'll go in and actually just cut out part of their bowel and give them an ostomy bag. Severe diverticulitis can cause this kind of stuff as well. Any kind of infection can cause this. So this is their stoma. These are the little bags that they use. There's like a little, I don't know how to explain it. It's like a waxy film looking thing that they used to put on to kind of create that barrier. It's like an airtight seal is what it is. So these can get infected around them. They poop. This is where they poop from now. So it comes directly into the bag. Another thing you might run into is you don't want to pop one of these things. I know that sounds like duh, but a lot of times they'll fill up with air because they can't fart either. So they fart into their bag. And so that thing will get like filled with air. So you have to go in and burp it. Cover your noses when it happens. It's not very nice. So yeah, if that thing's like busting at the seams, don't touch it. So this little bottom right here, you've seen the waterproof bags that you fold and then that's what it is. So like you unroll it, roll it down, and then you can just burp it out and then roll it back up and seal it again.
Vaseline in the nose first.
Yeah, Vaseline, mask, more Vaseline, like, what's that?
Dryer
called?
sheet.
Yeah, dryer sheet, alcohol prep pads, mask again, and then do it. Do you have a question?
Yeah. What happens to the butthole after, like, does it stay whole? They
No.
sew it? Like,
Do they sew it?
feel like you get
Hell yeah.
hysterectomy, like they sew
Right.
somewhere, like
Yeah.
the cervix will sew it shut or
Yeah.
whatever. It's like
Like your vaginal.
what happens to the butthole? Nothing's coming out anymore.
Never had
That's a
one.
really good question, because I've dealt with these, but I've never thought to be like, where's your butthole? I have never asked that question. That's a great question.
Somebody else.
You're all, that's a
I'm
trauma.
gonna Google this. She's gonna Google it. Oh, yeah.
Like, can they still
It took me a second, but I was just trying to stop it. Surgery, and she had her colon.
I would say that's pretty close to fucked up bubble right there.
Right.
She was like still drugged and she called me first. She's like, dude, they moved my asshole.
Oh, this is bad. I shouldn't have Googled this, bro. Oh,
No, no.
It is no longer used for passing stool, but it often remains in place and continues to produce this.
Ew.
I shouldn't have
Does
Googled
it
this.
leak out though, or do you leak mucus out of it?
Shrinkage of the anal canal,
Anal?
decreased sensitivity, mucus discharge. It just eats out of that thing.
You have to wear like diapers.
You would.
Oh, yeah.
Yeah.
I guess you still have to wear guys.
Well, I just
It's like you're walking, it's like you're walking and you're
Okay, on from leaky buttholes. So, dialysis. Who in here's like seen dialysis? knows somebody with dialysis, yeah. So usually what happens is your kidneys shut down, right? So kidneys are our filtration system. That's how we excrete our waste, right? So kidneys aren't working, dialysis comes in. Dialysis is in taking over the function of our kidneys. So most of your patients, it's a 3 times a week kind of thing, every other day. If they miss their dialysis appointments, it's really important to know that. It can cause a lot of electrolyte abnormalities and it can kill the crap out of your patient. So they can get hyperkalemia, so high potassium. If a missed dialysis thing, usually they're like really hypotensive, causes a lot of problems. Fluid buildup, basically like think CHF exacerbation with the fluid buildup and like really sick, and dialysis, very similar symptoms. So there's a couple different types of dialysis. So there's peritoneal dialysis. We actually have somebody here in town that does peritoneal dialysis. So this can be done in the comfort of their own home, right? So they have like their little bags of solution. They have a port on their belly. They put it in. That fluid goes into their belly, absorbs all of the toxins, and then they drain it out. So this is not super common to be called to. I've only seen it a handful of times. I deal with a lot of the other kind of dialysis patients personally. So again, this is done at home. So this fluid goes in, sits in there for a little while, and then they drain it out. So it is your kidneys now. So depending on how much kidney function, so it's important to ask somebody that's on dialysis if they still pee, because sometimes they will still pee and they can still get rid of some of their toxins, but a lot of times they won't even pee anymore just because their kidneys just because their kidneys are just done. So somebody that misses their dialysis, a lot of times what happens is like they get that buildup of potassium. They can have lethal like heart arrhythmias, really bad hypotension, sometimes severe hypertension depending on where they're at. But then another thing you'll see if somebody's really, really sick, it's called uremic frost. And so what that is their body is literally trying to get rid of those toxins and it starts seeping out of their skin. So basically they're peeing out of their skin in like a roundabout way. And it looks like a frost buildup. It's very disgusting. Think about what it is.
So that's if they just missed one?
No, usually the uremic frost builds up after a couple.
Normally, if they miss one, you'll just get like fluid buildup. This is when you see a lot of those like CHF exacerbation patients that have like fluid in their lungs, where they're having like difficulty breathing, their tum-tums all big, and they can't really take good deep breaths.
So this is what it looks like.
And this is what it looks like.
So it looks like, and it like flakes off.
Yeah.
Yeah, that's what it looks like. They call it uremic frost. So, yeah, so like Chaz was saying, it looks like it's very similar to like a CHF exacerbation. They get that buildup of fluids. If they miss their dialysis appointment, it's really important to ask why they missed it. Sometimes they go in to do the dialysis appointment, and they always check their vitals before they do dialysis. And if their vitals, like if they're too hypotensive, or if they're feeling sick, have a fever in any way, they won't do dialysis. And then they'll just send them home. Make that make sense? Right. Like you should send them somewhere else, but they're like, yeah, go home. You can't do dialysis today. This is great. So hemodialysis is the one where you go into like the dialysis center. I think there's one in Elko.
Yes.
There is one in Elko. Is there one in Winnemucca as well?
Nope. You guys shut down.
Oh.
It was DaVita. I passed it the other day.
DaVita is everywhere.
Yeah,
They
but
are
sucks.
They're cult. So they go in, they have fistulas, right? So they have, what they do is they take the artery and the vein in their arm and they connect them together. And so whenever they come in, they have 2 ports that they'll stick into their fistula, and then it cycles out their blood. It goes into a machine, cleans it, and it goes back into their body. So fistulas should be a patient picture. Is there not a picture? No. Okay. Oh, I'm gonna look up a picture of a fistula for you. You can see it. So fistula.
Was the arm one on the next slide not it?
No, that's a big one.
Oh, okay.
So fistula. Has anyone in here ever felt a fistula? They're very cool. Fistula. I was just Googling bubbles. I can't. So. He's like So, this is usually about what they look like. And you'll have patients where they'll have like fistulas that they had that failed, so they'll put in a new fistula, so you can have a lot of scar tissue. So usually it's just like a giant tube looking thing up under the skin. And they're very cool, actually, if you ever have a patient that has a fistula. So whenever you feel a pulse on that arm, or you can just rest your hand like on the fistula, it feels like a thrill. It's like as you're feeling for a pulse. It's very interesting. So it's an arterial venous or an AV fistula. So what they do is they go in and join together like your arteries and your veins.
And you can't do a blood pressure cuff on.
Correct. Yeah, so no blood pressure on this side. You don't want to cause any kind of damage to that fistula at all.
So these in Atlanta, they would be the people that were on these dialysis for like years and years would just have knots all up and down their arms. So they might have them up and down both arms. So knowing where like their active fistula site is, like she's talking about, touch them and you can feel them. So if you ever go out on like an unresponsive dialysis patient, they have a bunch of these knots all over them. Put your hands up and down on all those knots to try to figure out which one's still active. Because they'll still have these big giant knots all over the place.
No, they'll like sew them up, or they'll like close them, but they're still knots. Like, so they'll only use the ones that are active. They'll fail. So they
And then the ones that are active will have that.
Yeah, the ones that are active will still have that like thrill to it.
So that's usually like
Do
that.
dialysis patients have more than one fistula?
We haven't quite gotten a fistula yet. So they'll do it.
At one time,
Yeah.
they shouldn't, typically they shouldn't have more than one active fistula site. So they should only have one active fistula site. So just,
Yeah.
that's what I said, if you're in an area that does like a lot of dialysis and you have somebody that's been on dialysis for like years and years, then they'll get those like knots all up and down
Oh,
their
it's just a
arms.
C-clamp.
And they'll be all up here, they'll be all up in their bicep and stuff, so just like put your hands on them, just see which one has that like thrill to it. So you know which one's active and which ones aren't.
Yeah. So in the dialysis centers, when they pull out their needles, they have to clamp it with this thing. Like, I don't even know what it's called. Dialysis clamp, fistula clamp. And so it's to stop that bleeding. I have been on a lot of patients where their fistula starts bleeding. So you need to try and avoid using a tourniquet. Try and just use like positive pressure on it, because if you tourniquet up above it, you're gonna ruin that fistula again. So try and put direct pressure right on that fistula. Or if they're still at the dialysis center, they should know to just put one of these things on there. But they bleed like a suffocate. So I've actually had it, it wasn't the cardiac arrest where they were bleeding out the fistula. Who was that? They never stopped the bleeding. They're sitting there working a cardiac arrest. Oh, they're bleeding from their fistula. That might be why they're dead. So, yeah, so fistulas, again, they might be using something like this. So, there's central IV catheters, and then there's like PICC lines. You just take a little guppies.
He looks like he's got a chicken baby.
Come on, me.
He's just gonna.
Tommy, you're in there.
He's going to the kitchen now.
No, don't eat them.
You make little duck nuggets.
Yeah, he's gonna walk back with your nuggets that you had earlier. Okay, so these central IV catheters, you can see them here, you can see them in the neck, and then the PICC line, so the peripheral inserted ones are like usually up high in the arms. So they have different ports. Usually they're HEP locked. So what that means is instead of just using saline to fill them while they're not in use, they'll use heparin, which is like an anticoagulant, because they don't want those to clot off at the end. So we're not allowed to access these as paramedics. You guys aren't allowed to access them at all. So don't go just slamming stuff into them. A lot of times, so these central IV catheters, they're a direct shot right to the heart. So again, infection should be very high on your list. If you have something going on, you can't quite like pinpoint it, check around that site, because if that gets infected, again, direct line to the heart. So most commonly, I've had these where they're yanked out and they'll bleed quite a bit too. Again, just pressure bandage them, take them to the hospital, they'll get a new one put in. The catheter for this thing is like long, it's super long. If we use little IV catheters, these PICC line catheters are super long. So different ports are used for different things. Don't ask me what they are because I could not tell you, but they are clamped off. So. Any questions about this? So central venous line, you can see in here, if it is inserted up high, you see how it goes directly into the right atrium. So again, you want to be very careful. Might have multiple IV tubes. And then this is a port. So a lot of times like chemo patients have ports that they have to access. They're kind of cool feeling. They're implanted. Also, you got to be very sterile if you're going to access them. I used to work at a place where paramedics could access them. They just feel like a little Lego piece up under the skin. There's like 3 little bumps on this little plastic piece. And then these little needles that you use, you have to clean the site, make sure you're not breathing on it, and you just poke it right into the center of it. So 3 little dots, right in the center of those 3 little dots, that's your access point. You need to be, if these are accessed, you need to be very careful, very mindful of infection. So anything that's like stuck in their skin, just be really on high alert.
Do these have like a bubble at the end of them or the balloon at the end of them to keep them where they're supposed to be?
These ones do not. So they're called Huber needles. So depending on how long that needle is, it'll stick in there, and then you put like Tegaderm over it to hold it into place. They don't like screw in by any means. They don't like have any other form that holds it.
And then what about the central venous line?
I believe they do, or they might be stitched in. They might be stitched in. I'll have to look. I don't think that they have like a pilot balloon or something. We can look. That might be one of those little 3 things that stick out. I'm not sure. All right, so if it looks like this, that's bad, okay? So red, hot to the touch. If it looks infected, it's probably infected. Do not go yanking it out. It's not done. Don't go yanking it out. Don't put the AD pads on it.
Was it biting you? Or what?
Bite it back.
Bite it back.
Right, Frank?
It's
You know those squeezy toys with the squeeze?
Stress Ooh, damn, he's still trying to get you.
Yeah.
Holy
I'm telling you, this was a dick. That's the whole reason why I grabbed him out, because he beat the crap out of everybody.
Was he?
Now they're all sleeping all nice and peaceful, then he puts that one back in.
Yeah. It's cute.
You done?
Nope. No, not good. Okay. VP shunts. Ventriculoperitoneal. Okay, VP shunts. They're in the head. So they are placed in there. What they do is they drain excess CSF fluid down, usually goes into their belly. I have had patients that he was young. I don't remember. He looked like he was probably 6 or 7. But I think he was like in his teens, very small, had a VP shunt. You could feel it drain. I was like carrying him to the stretcher and I felt it like whoosh, like down. So whenever they have a buildup of this CSF fluid, they can cause like altered mental status, seizures, basically think ICP, right? So there's too much fluid going on in that skull. So this is supposed to keep it out of there. Oh yeah? Is that what you think about them?
Ooh.
Spicy. He's like, let me out of this thing.
This one's a dick.
First one is
There's no, all I can see is like from here up on the book. There's no reason to be spicy. Reason. It's okay. Like, let me out. I need to create mass chaos. All right, so this is what they look like. They're like little shunts up in the head. So drains out, goes into their belly. Again, you can feel it when it drains. Sometimes it's just like, but he was having seizures, so I don't know if it was like malfunctioning or if it was just part of his epilepsy. I don't know. So if that thing stops working by any means, it's a bad day. All right, so physical impairment does not mean mental impairment. So if someone has hearing loss, don't talk to them like they are 2 years old. They're still adults. So if they have hearing loss, you can ask about their hearing aids. Make sure you bring them with you. If they don't have the hearing aids, you can write on paper. Another trick of the trade is to do this stethoscope thing. So you put your stethoscope in their ears, and then you talk into the bell, and it amplifies the sound. So that's one thing you can do. These TDD, TTY phones, I've never even seen one of these. If anything, I'm going to text it out and just like show it to them. So I don't know. I have no idea.
There was a doctor here that had one of those things.
Really?
Yeah, had like a crazy accent. He was talking to us like write notes or whatever.
Oh,
And that's
okay.
what it looked like. Exactly that little thing.
Huh. Their little
I don't think he's hearing one.
charting thing.
Yeah.
And then impairments of sight. Please be mindful if someone is blind, that you're describing to them what's going on. Because as you start to load somebody up into a stretcher, I've made this mistake. Load someone up onto the stretcher and in, all they're hearing is whirring. And so they were like, please explain to me what's happening. Like they were freaking out. So please try to kind of like, hey, this is what we're going to do. We're going to move you this bed. You're going to hear whirring. We're just lifting you up. Like let them know what's going on. Let them know if you're going to do an assessment. Again, we're still going to ask, can I do a 12 lead? We're not just going to start touching on people anyway, but especially if they have like poor or no vision. So don't just go assuming, right? I'm always going to transport the dog, whether it's a guide dog or not. So that's my personal thing. So it's up to y'all. If they have a guide dog, you, according to Americans with Disabilities Act, we're supposed to be transporting them anyway. So now if they're like, oh, they're my, service animal, and the service animal is trying to bite your face off, it's not a service animal at that point, right? So they're trained not to do that shit. So. All right, so aphasia. This is something I want to clarify before we go any further. This can usually be caused by a stroke. So what's the difference between aphasia and aphasia? The energy, very good. So aphasia is difficulty speaking because it's an S. Okay, aphasia is difficulty swallowing, but how I remember is they're gonna gag on everything. Make sense? So you can have a stroke patient that has aphasia and aphasia, but they are two different things. Why they made them sound so close together is beyond me. So.
What are the roots words?
So aphasia, apha is difficulty. So like, what's another word? Dysphagia, right? Difficulty. Why can't I think of another word that has this?
But so you just add the dis to the aphasia.
Yeah, because you can have dysphagia too. So I think this is completely without. So they can't speak, they can't swallow, but then you have dys, which is difficulty, like dyspnea.
What's the GI thing? That
Oh, I'm not sure.
oh,
We can do. That's it.
I don't know if it really matters, I'm just curious.
Maybe glottis. There you go. Speech. Speech. I have no idea.
That's a good question. What part of the brain
What
functions?
Latin bullshit is this? Yeah, I'm not sure. So absolutely without, this would be difficulty. So if they can't speak, so there's different kinds of aphasia. So there's Wernicke's aphasia, there's Broca's aphasia. So there's a possibility that they can see something, but they just can't tell you what it is. And then there's, which one? I can't remember which one's which. Wernicke's one of them, and then Broca's is another. So there's one where like Google Translate from here to here is broken, but then there's another one that's like they can still talk to you, but they can't identify stuff and tell you what it is. Either way, if someone's having a hard time communicating, try and communicate with them as best as you can. If they can type it out, have them type it out. This can be very difficult for people if it's like a new onset. If they've been dealing with this their whole life, that's one thing. But if you have someone that's having a stroke and all of a sudden can't talk or has a hard time forming words, it's going to be very frustrating, right? So try and just figure out a way around it. Sign language. I know this much sign language, so I usually just give them a piece of paper to write on or something. So I know cookie, I know dance, hospital, sharp pain. That's all you got on it. That's it. So. This one. All right, so difficulty walking or standing. So ataxia would be another word for this, right? So we've seen that video of the ataxic gait. So if they have a walker, bring it with you. If they have a cane, bring it with you. So those big old rascal wheelchairs, the electric wheelchairs that people carry around, or they ride around on, we're supposed to take those to the hospital with us. Has anyone ever tried to lift one of those things?
Yeah, they're heavy.
They are heavy as shit, and they're not going to fit. Yeah, me neither. They're not going to fit in the back of your
In
ambulance.
Atlanta, we used to have to call a supervisor to come and pick up. I don't care what my problem is.
Yeah, be like, so I'm taking this patient. Good luck. All right, so abuse and neglect. So it's important to know like the healing stages of a bruise, because if you have a patient that you suspect like neglect and abuse on, they'll have bruising in different stages, right? So this yellowing, they start to get that yellow around it, it'll be bright red. Repeated injuries, so if you're going out to the same address more than once for like something that's suspicious, you need to report it. And then if the caregiver is like depending, this says caregiver's indifference to the patient, but whenever you do any kind of like human trafficking training, they teach you that it's usually somebody's like standing over them. They won't let that person out of their sight. So one or the other, right? So if they're completely like, yeah, they're fine, whatever, that's one thing. But then also if they're like overbearing to a point that like it's concerning, that also needs to be considered as well.
If you do run into one of these trafficking situations, try, if you have a female partner with you, even if you're the higher care provider or whatever, try to allow them to be in the back of the truck with them. Just makes things a lot easier for you. And me and Becca ran into this a couple of times when we were in Atlanta. How old was that girl? 14. And she escaped from like this big sex trafficking situation. I didn't even get in the back of the truck. I put back in the back of the truck with her, and I just left the door. Becca told me when she was ready to go. So.
Yeah, so like an example, like trafficking example. So I had a patient, she was very pregnant, and she was just inconsolable, crying. And we got there, you know, I was just doing a normal assessment, like, okay, with her. And one of the firefighters, and the guy was like overbearing, wouldn't let her out of his sight. And one of the firefighters there was like, hey, like I was just at the same exact address a couple weeks ago for not her, but another pregnant chick, like just as pregnant, at this same house, same kind of deal. I was like, okay. So got her into the back. The dude was like, I'm getting back there. That's my wife or girlfriend or whatever. And I was like, oh no, because COVID, we can't let y'all ride back here with us. You have to follow. So locked him out and then was asking her like, you safe? Like, what's going on? And she's like, no, I'm not safe at all. So like, would she have told me that if he was standing right there? COVID's a great excuse to keep people out of that. Be like, ever since COVID, we're not allowed to let people back here. So I do that for that kind of stuff. But just be on alert. Yeah. Atlanta was a little bit different because it was like the headquarters, capital of the trafficking world. So all of that happens in Atlanta. There's a big instance of it. So abuse in kiddos, this 10 faces thing is used kind of across the board. So the 10 is torso, ears, and neck. If they have bruising on their torso, their ears, or neck, these are like suspicious places to have bruises for kids. Like I get that, like once you hit your toddler or like a little bit older, they run around, they're rambunctious. I get that. But like usually their ears, usually their neck doesn't get bruised. Sometimes their torso, but rarely. It's usually like knees, elbows, arms kinds of things. So frenulum, I don't know what frenulum they're talking about because there's a couple of them. So where your lip comes together right here, where people get that smiley piercing, that's a frenulum. But also the tip of a wiener is called a frenulum. So I don't know which one they're referring to, but either way, you shouldn't have bruise there. Angle of the jaw, cheeks, like the fleshy part of the cheeks, eyelids, and then check around their eyes, like so subconjunctival is like around their eyes, like the whites of their eyes. If you see any kind of like small bruising patterns in there, like petechiae, that's really important to take note of. So usually that's like a strangulation kind of thing. So they'll get those little tiny bruises up in their eyes. On the bottom of their like lips, you'll see it as well. You pull down their lip, you'll see a bunch of little tiny bruising spots. That's part of like this 10 faces, right?
So on the ear one, is that different than the battle wounds when we?
Yeah.
Okay.
Yeah, so it won't be so much like because of a basilar skull fracture. It'll just be the location of the bruise. Because kids usually don't bruise up around their
Typically
ears.
from like where like parents are slapping or punching their kids out of the head.
Yeah, that's a good question because, I mean, you might see that kind of stuff too, like shaken baby syndrome or like if they beat their head. But usually, if the kid's like around and you're seeing bruises like around this area, that's concerning. Infants, so 4 months and younger, kids don't jump off beds. Kids don't like fall off stuff if they're that young, right? Infants just kind of sit there, they do their thing. So for them to have any kind of bruise is pretty significant. That's something that could be concerning. Okay. And then pattern bruising. So if it looks like a belt buckle, if it looks like a cord, if it looks like a handprint, those are things that are also concerning. So, yeah. All right, so child abuse, a very common thing is they dip their babies in hot water. So if you have like a very like distinctive line, like in this picture, a lot of times it'll be like on the bottom of their butt cheeks too, because as they dip them, they'll pull their feet up and it burns their butt. So that's something that you want to, you know, obviously if they have burns at any point anywhere, those are things that can be concerning. Kids like to grab things on stoves though, so think about that as well. Psychological, emotional abuse, that's a hard one to prove, right? So I've had a lot of like teenagers, younger teens, preteens, they're like, I'm emotionally abused. And you're like, okay, tell me how. And they like, my mom yelled at me. Okay, that's not the same thing as like, you know, like true, really bad emotional abuse. Physical abuse, sexual abuse. So what constitutes neglect? So whenever you make your report, because you're a mandatory reporter, you're not going to get in trouble ever for making reports, right? But there's other sides of that coin where people have to go in and investigate whatever you reported. So they have to go in and say like, okay, does this person, are their needs met, basically? Do they have food? Do they have water? Do they have a reasonable living situation? So these are all things that get investigated. And if anyone's ever watched like what's the Gabriel Fernandez story thing. Yeah, awful. It's horrible because a lot of times these kids are like let through the cracks. There's abuse going on. So he was like severely abused by his mom and his mom's boyfriend, and they were keeping him like in a closet. Multiple teachers had like reported like instances of abuse. He stopped showing up to school. They did welfare checks. They would do all the things. Nobody did anything about it. There was no like severe investigations done whenever it was reported. Well, then they found him dead. And so when they found him, they did the autopsy. He had like broken bones at all different levels, broken ribs. The only thing that was in his stomach was kitty litter, like severe neglect, severe abuse. And he was reported multiple times. So like, why wasn't anything done about that? It makes you want to punch somebody in the face. But I mean, what do you do, right? It is a broken system, and that's the problem. Like, I don't foresee it actually fixing itself anytime soon, because it's not only a broken system, but it's an overwhelmed system is what it is, right? Because you look at like foster care, you look at like how many people are available to help foster, the criteria that these kids get sent back to their parents by, like it's broken. It's really sad. It's horrible. Yeah, because you did foster care, right? Yeah.
All they're worried about is the parents.
Yeah. Yeah, they don't.
give a shit about the kids.
Like, it was bad because me and Becca had a call one night at the South Fulton precinct in Atlanta, where this lady showed up with her like 1-year-old, 2-year-old.
He looked like he was freaking 5. He was linebacker, but he was only like 2. He was a big kid.
He was big.
It was like the Blindside situation going on.
And so like,
It's ginormous.
they showed up and it was like, I don't want this baby no more. Child Protective Services showed up and was like, we didn't bring a car seat, so we need an ambulance. Why the freak you show up with no car seat when you're coming to pick up this kid? Beyond me. So me and Becca show up and this kid's like sitting on my lap, just chilling. Think that he had like some developmental delays because he literally didn't make a noise. Literally didn't make sense. And we took him to the hospital, the children's hospital in downtown Atlanta. And at that time, me and Becca weren't dating, like we were just partners. And Becca made the comment like, oh yeah, I'd take this kid home. And the lady was like, I will get you paperwork right now. And you can walk back out the door with it. Like, that's how overwhelmed that system is. And they were ready to just be like, here you go. And the only time I ever heard that kid make a noise was Becca made him like a little blow-up freaking glove turkey thing. And the nurse was like, he can't have that. He's going to choke on that. And Becca was like, well, I'm not taking it from him. You can. She took it from him. He was pissed.
He really liked my hand turkey.
So it's not fun. It's really unfortunate. So
Yeah, that's bad.
out here, it's not as prominent. It still happens, so still keep an eye out for it. In Atlanta, it was a very common situation to run into. But
Yeah.
Now their hospitals are asking the kids if they have food, shit like that at home. Even the elderly, not elderly, but
one of the only pediatric arrests I've ever ran was on a 12-year-old that was strangled and had cigarette burn marks all over. So, I mean, back around that call together too. So.
It's a sad deal. Like, just like the stories are endless, right? Like you could always talk about like the stories that you see, but like I had a kid. Mom said that she just found him unresponsive. Arm was broken, but he had a like makeshift cast made out of duct tape. So like he was never actually taken to a doctor. Dead. Worked him, took him into the ER, they called it. Come to find out that he had a twin that had died 6 months prior under the same circumstances. So like, why wasn't he taken away? Nobody knows. But now he's dead too. So I have to think about it like they're in a better place now. They're no longer suffering, which is really shitty. Like it shouldn't be like that. These are things that you see in a job. Okay, so again, we talked about this, I think Jessica was asking about it last Tuesday. So if you suspect something, what constitutes as a report, right? So we talked about it a little bit, I'm just gonna touch on it again. Just telling the hospital, the receiving hospital, isn't enough. You need to get law enforcement involved, and then there's websites you can go on to and create mandated reporter, like sheets, and they just automatically send them in. Sometimes they'll get back a hold of you and let you know whatever came of it, and sometimes they won't. So it's purely dependent on whoever's doing the investigation. So Chaz dealt with like a neglect case out here with an elderly female, and you still haven't heard the outcome of any of that. So
She's not home, so that's good.
yeah, so it's purely dependent on who's investigating the case. All right, so physical and sexual abuse are commonly seen by EMTs whenever it comes to like child abuse. Rarely do you go out on like the emotional abuse kind of thing. It might be something that gets presented, like again, I've had kids where I transported them and they're like, I'm emotionally abused. So again, use that to your own discretion, how you're gonna report it. So shake, throw, or push children, that shaken baby syndrome, that's a big thing too. So if you have a kid with unexplained seizures or unexplained altered mental status, and you see like any signs of ICP at all, that increased cranial pressure, you need to suspect shaken baby syndrome, which is horrible. But so physical injuries of sexual abuse, again, if sexual abuse happens and you are on that call, so expect to go to court. So make sure you cover your butt with any kind of paperwork that you have. But also, like, again, people that are sexually abused, the first thing they want to do is change their clothes and take a shower. So try and avoid that initially so they can get through their investigation. And then any kind of clothing needs to be kept in what kind of bag? Paper bag. Very good. So assessment, so repeated vitals. If it's going to be like super traumatizing, don't be like, hey, I need to see this, right? Unless there's like a considerable amount of blood, take them at their word, report it. If you don't have to do like a detailed assessment, don't do it, because they've already been, their little personal space has already been affected. So if they have like malnutrition involved in like an abuse, a lot of times their wounds don't heal as well, right? So if they're not fed well, their bodies aren't going to heal the same way. So multiple injuries, fracture complications, same kind of thing. They're not going to heal super well. So are their parents or guardians inappropriately concerned? Or are they just like, yeah, whatever? If they have anger outbursts on scene, that's another indication that should kind of clue you in for things. And then any kind of indications for substance abuse. So I ran a call in Idaho. It was a meth lab, and there was kids in the meth lab, and they were having like seizures and stuff because there was like a buildup of it on the walls, and they were exposed to all of it. So obviously that's kind of obvious because it's a meth lab. But if you kind of look around the scene, see what you can see, any kind of weird things, sure. So rearrange or remove clothing. If there's bullet holes, stab wounds, don't cut through it on the clothing, cut around it. If there's obvious injury of the genitalia, then you may assess it, but if you don't have to, don't put yourself there. Like, give them their space. Calm and reassuring. Again, you have the one-offs where like it's a female and she wants a male provider in the back with her, but most of the time if you have the same sex provider, keep them in the back with that patient, because it's like calming for them, or they might feel more comfortable. Try to control your emotions. If you are suspicious of anything, don't just out loud on scene be like, oh, this person's being abused, right? So you don't want to stir up anything that doesn't need to be stirred up. So try and keep everything to a minimum, and then protect the child from embarrassment. So again, like sexual abuse especially, people are very shameful of, even though it's not their fault. They feel like it's their fault. So you need to make sure that that you are reassuring to them, that you're not like in any way, shape, or form making them embarrassed or talking about it out loud with people that don't need to hear it, right? Because they're going to be embarrassed. All right. Elder abuse. So very common. Again, this is like one of those caregiver fatigue things. Also like dependent adults A lot of times what you see is like monetary wise. So their kids are like, oh yeah, I'm getting the check from mom, you know, and then they kind of just like leave mom in a corner and they're just living off her social security. So that's a very common thing that you see. So people that can't really take care of themselves are very susceptible to this. So unexplained absence of caregivers for long periods of time, hunger, malnourishment, improper toileting. So exception to the rule, I've had like older patients that absolutely refuse for any of their family members who are their caregivers to clean them up. So like I've showed up and they were sitting in days of their own poop because they just would not let anyone clean them up. It ended up being like a psych thing. But still, like those are things that you want to assess. And then their interference with your assessment. So if you're trying to do an assessment and they're like, well, let me tell you this, let me show you this, and like getting in your way, those are other signs that you should be concerned. This whole slideshow is pretty dark today. I feel like we need to watch like SpongeBob after this or something. Okay, so reporting mandates, they are going to differ from state to state. In the Nevada, in the Nevadas. So we are mandated to report within 24 hours of becoming aware of a situation. So law enforcement should be the first thing if they're not already on scene. In Battle Mountain, they're going to be already on scene. This is like a rare circumstance. And then here's your numbers to call. There's also websites that you can go onto. So literally just Google like mandated reporter website for child abuse or adult abuse or whatever, and that'll come up and there'll be forms for you to fill out.
Contact law enforcement and call one of the numbers?
Yes, yeah, both. And let the nurses know, but just letting nurses know isn't enough. You have to do.
Tell all people.
So how would you go, like, about, like, so if you were there and law enforcement wasn't there for any reason, like, how would you go about calling them without?
Just contact them after you get to the ER.
Yeah, you can have them net you at the ER usually. That's what we would do in Atlanta. Because a lot of times if I'm like suspicious of abuse, I'm not hanging out on scene by any means, right? So like I'll just call them and say, hey, can I have PD meet me at this ER for whatever reason? And a lot of times, like Grady was a specific facility for abuse. So they handled trafficking, they handled sexual abuse. They were like the hub of all that. So a lot of times they had their own like officers in the area that would respond to that.
Like,
So.
if the abuser, like, say it was like a parent and they were there and they're like, well, I'm going with you, do you just bring them too?
No.
No.
So you can get out of that, right? So like, it depends on the situation. If you're dealing with a pediatric patient that you're suspecting abuse on, you can call PD directly to your scene and have them, if you're like, no, like you can follow us down there, and they're like, no, I'm going with you. You can have PD meet you on scene and tell them, no, break off. Or just, try to convince them to ride separately. And then as you're going to the ER, when you call the ER, say, hey, this is what I have going on. When the parents get there, don't let them back into the ER immediately. And, they have locked doors in there, so they won't let them back there immediately.
Yeah.
And PD's trained, the sheriff and the police department are all trained on this stuff as well, on how they handle it on their end.
Yeah, so like the case that we had here, I had like the initial contact with one of the deputies, and then they ended up calling the detective, and then the detective had to come down there, and then he had to go through like his whole processes of like gathering all the information and going back over to the scene and like assessing everything. So yeah, they kind of have their processes of dealing with it.
Yeah, and like if you bring someone in and like I've had people ride with me, if I can't get them out of riding with me, I'll still say like you need to check in at the front desk. You can ride with us, but you check in at the front desk, and then I let them know like, hey, don't let them back until you do whatever you're doing. So if you can't get out of it, there's like ways around it. It's hard when it's a minor because parents have to say so. So that would be like one of those things where you call PD or SO directly to the scene so you can kind of separate and they can do their thing. So.
They're already like
That's not,
Yeah.
they go to escalating too much. We have deputies around here that are real taser happy. So,
Yeah, I wouldn't like outwardly be like, I need PD on my scene. I would step out and request them. I wouldn't tell them that was happening. And then by the time PD gets there, if they want to box, they can box. So
you can like step out.
yeah, I've done that a few times actually. Like just step out and be like, hey, can we get PD headed this way for this? And usually they'll expedite if it's something like that. So they'll get there. Yeah, your partner will hang out with the patient, or you can have your partner step out and ask, or usually if you have like fire department or somebody else on scene, you can request for them. But obviously don't make it obvious. Don't be like, call the police, he's abused. Don't do that. Yeah, so try and keep it on the down low. You're trying to keep everything like chill until somebody else gets there. Okay, so suspected, try and transport the patient, even if it is very minor. If you're suspecting any kind of abuse or neglect, get them out of that situation. So there's processes that can be done with the hospitals, law enforcement. And then whenever you report, just don't be like, I had a sneaking suspicion. Like you need to give facts as to why you're suspecting abuse, right? Because if it comes back on you for whatever reason, say you get pulled into court, I'm not saying you're going to get in trouble, but if it ever gets pulled back on you and you're like, yeah, I just had a gut feeling. What made you have that gut feeling? The patterns of the bruising? Was it like the size of the child? Whatever you see. So make sure that you're reporting the facts. And that's for everything across the board, right? So we're all adults here. I'm sure we've all dealt with it at some point or another. But like I learned that lesson from watching someone else. There was like someone taking narcs in Idaho, and they had someone else write up their report as to why they saw them taking narcs, or they thought, and they ended up like getting pulled into a bunch of stuff they didn't need to get pulled into. And he sat me down. He's like, if you ever get told to write any kind of, what's that called? Like a report on somebody, just only put objective things in there. Don't put any of your feelings in there. Just be like, this is what I saw. This is what I witnessed. Thank you for your time. Basically. So that just goes across the board for everything. All right. So this was the only picture I could find on Google of the girl beating the boy, because all the other ones are the girls like, but this happens too. Not to Chaz.
I don't know, he's side-eyeing, it's kind of weird.
Don't let him lie to you.
Elbow last week.
No, I had to put this in there because it does happen, right? But I think it's funny if you Google pictures of this, like put in a slideshow, it's all men beating women. So usually it's a pattern. It's not an isolated incident. So I've had a few pep talks with people where I'm like, it's not if they kill you, they will kill you eventually. It's when they're going to kill you. If you're in like any kind of domestic abuse. So it's really important to get out of that pattern. The problem is like, it never starts out with them just beating the crap out of their partner. It always starts out with like small little things. Then they slowly work up to it. And it's like, oh, it's fine. It's not as bad. It's not too bad. And then it just keeps getting worse and worse. So.
There's like 90%
Yeah.
and then the 10%.
Yeah.
That's what's bad. I think that it gets.
Really bad.
Yeah,
Right.
and that's what gets domestic abuse people if they don't, or victims, if they don't. When you look at the out there, this is a really bad.
Yeah. You don't have that like third person point of view.
Yeah.
Yeah. And a lot of it's like a love bomb, right? So like, something happens and then, oh, I love you so much. And then, forgive me, please. And then they forgive them, and it happens again. There we go. All right, so physical signs of abuse. A lot of times they're scared to talk to EMS or law enforcement. Again, a lot of your domestic abuse, they're isolated. So they truly believe, they are told by their abusers, and they believe it, that nobody's ever going to love them again. They're not going to deserve anything. They won't have as good of a life without that abuser. And so they just stay in this awful cycle. So delays in seeking treatment, a lot of times you don't get called until it's really, really bad, because a lot of times that abuse is not reported in any way. History inconsistent with injuries, the common, oh, they fell down the stairs thing. Yeah, no. And then unusual interactions with partners, so. Medical issues get attended to first. Do your original like treatment of problems, right? Stop the bleeding, do the airway stuff. Here's the National Domestic Violence Hotline. So they have a phone over here that's the domestic violence hotline as well. That rings. It rang the other day. Nobody was there, but it rang. Myra picked it up and was like, domestic violence hotline. Nobody was on the other side. So, so you guys, your role is to treat, evaluate, gather your information, and then report your objective findings. Again, objectively report back. Yes. Yeah. So same kind of thing. Like, even if it's a minor abuse thing, you should try like something that's not like necessarily would warrant a trip to the ER. You still want to get them out of the situation. So just transport them if you can. Yeah. Good point. All right. So human trafficking. So the exploitation of a person for compelled labor or commercial sex act through force. So abuse, malnutrition, STIs, mental health issues, drug abuse. So they get sedated, they get addicted to things, certain drugs, and that's what keeps them in the human trafficking. So some signs that you might see, so urinary difficulties, pelvic pain, STDs that are either treated or untreated, pregnancy. Again, look for that like overbearing partner. Look for like patterns at certain addresses. Serious dental problems, malnourishment, phobias. A lot of times like language or cultural barrier is a big one. So immigrants get put into this all the time. There's not a lot of people out there advocating for them. And so they kind of just get human trafficked. There's another thing. If they have signs and symptoms of a delivery and there's no baby, also a sign of human trafficking. So they will cut babies out of people, or they will take the babies after they're delivered and take them away from mom. So that's a very common thing in human trafficking. Awful, horrible. So this was as of 2023. I think it's changed a little bit, but human trafficking victims per 100,000 people. Look at what's number one.
Jeez.
We're doing good. So I think this is updated. I don't think Nevada is number one anymore. I'd have to pull it up. But as of 2023, Nevada was really bad.
I don't know, they had a big thing on human trafficking there at the Flying J in Winnemucca, so.
Did they?
Yeah. Big ol'
I
article.
believe it. I mean, you think about like how much nothing there is out here. And then you have Vegas, right? So, and Reno. So, yeah.
I'm pretty sure it was Reno that was the issue.
Was it?
I was reading something about it a while ago.
Reno's on that I-80 corridor or something.
That makes sense. Yeah, so good job, Nevada. Hopefully we're doing better. All right, so medical issues come first, obviously. Trafficking is perpetrated by sophisticated and dangerous criminals. Consider your seat safety. Again, don't walk around being like, I think this person's being trafficked. You don't want to start something you can't handle right there. And then immediately and discreetly notify your law enforcement, notify the hospital. If you have a certain hospital in your area that's like specific for treating these patients, they need to go to that hospital. So, like Grady was that. Grady was like a trafficking treatment hub or whatever they called it. All right, what questions do you have? I know that's very sad. That's a horrible slideshow. I'm only 6 minutes late today.
Only 6.
Where are those ducks? Those are my babies.
Yeah, where are those ducks at?
I don't smell anything cooking.
Alright, so we'll come back next week. We have operations. Pretty odd. I don't think any of these really belong. Yeah, sure.
Then you said the week after we're flopping a couple, right?
Yeah, so, we're probably gonna change 40 and 41. I keep the homework and everything the same, but, like I don't really do like education and all that stuff. And the highway safety one talks about extrication, positioning emergency vehicles, stuff like that. So I'll do that one, and then Becca will do the terrorism one on Tuesday, because I won't be.
But you said you'll keep the homework the same?
Yeah, everything else will be the same, because the test for 40 and 41 will be on the same day, and then the test for 38 and 39 will be on the same day.
And then, so the date for our NREMT, that's on our paper that we got, isn't the date for that?
No, we're
Right.
probably gonna change it, because here's the thing. We'll play it by ear. I don't see us needing a whole month and a half of test prep, and I can only do so much test prep, right? Like, we can only do Kahoots and freaking mock tests so many goddamn times before everybody's sitting in
He's
here.
sitting there and he's like rocking in the chair listening to the music. He's like, fuck thanks, you guys.
Freaking listening to the Kahoots music over and over again. So, yeah. So,
Just you will go to Dougie's.
you got a spicy duck?
All my friends' snuggles, they were a little snuggle puddle, and this one started pecking another one in the eyeball. So he's on timeout.
Dude, he just needs
He's
a.
on timeout.
He's a dig.
Okay,
So, yeah, I'll let you know about the test date, and then we'll go from there. Cool? And,
Bring anything that day?
no. So when you come in to test, you will not have anything. Yeah, you can leave it in your vehicle, or you can bring it in, and we'll have like a table set up for y'all to like put stuff. But when you come in here to take your test, you can't have your cell phone,